welcome back to another episode of BEaTS Research Radio. And now, again, streamed from the University of Ottawa Higher Institute. This is my lab. I'm all by myself again. Been working for myself and for a long while, but I think it's okay. Safer is better for everyone. So today's episode is going to be a special one again, and we have a wonderful guest, Dr. Doug Manuel. He's a full professor at University of Ottawa with the School of Epidemiology and at the Ottawa Hospital Research Institute. And Dr. Manuel is one of those really special physicians. He defines himself as a public health physician, and I could actually spend most of my day of today's episodes, listing the wonderful CV he has. But one of the things that it really actually captivated me from his trajectory as a scientist is the ability of transitioning from being, a family doctor all the way to working in public health and epidemiology. So today is truly a privilege, and you're going to have the website from Dr. Manuel you have to visit. And I strongly recommend you so we can all learn more about what he's doing these days during the pandemic we're living in Canada. So thank you so much, Dr. Manuel, for being with us today.
My pleasure.
So let me start by asking you the question we normally ask, when we interview scientists in here at the radio. It's like, how do you become a public health physician?
I did, like you said, start as a family doctor, and I worked up north in Canada. So north of Canada is working with Indigenous populations for a lot of the time. And I was in Churchill and Northwest Territories, and really had a wonderful time working with the Inuit and Cree and Chippewayan. But I had a sense that, I would be there 20 years and I'd be tighter and people would be sicker and I would just be spinning my wheels. And that really kind of made me a little bit of soul searching. Like, what am I about for a physician? Am I about treating people that arrive to hospital, or am I about true health of the community? I was always kind of drawn that way, but I think that work really led me to come back to residency program in public health and really start thinking about the determinants of health. How do we make communities healthy? Not what we do is in the hospital, but how can we help the community, work with communities to make them as healthy as possible. So that was the return to public health, and really from there it was research. Again, like for public health, it's a lot about I say as a doctor, we sit with a patient, we ask, do you smoke? Or what's your blood pressure? And we measure their blood pressure. In public health, we do that for entire communities. So our toolkit is different. We have to know how many people are smoking in the entire community, or what the blood pressure is in the entire community. And that's a different toolkit, like epidemiology and working with surveys, working with large data. And so very early on, I was working in one of these centers where we have all of this population data merged together, and working on methods to bring that data together to really, I think, answer two questions, like how is our health and how could it be better? And for a lot of that is modeling the same sort of concept that we're seeing with COVID, like what's going to happen in the future based on what we know today. A lot of my work is around chronic disease, but I've done a lot of communicable disease over the years as well. I've been a field epidemiologist. I've tracked those diseases, flying around the world, and I worked in the Kosovo crisis, setting up surveillance systems in the refugee camps. Work with many outbreaks, so it's kind of natural. I got a call, from our hospital and others saying, "Can you help project how many hospital beds we need and others?" And that's where I kind of just pivoted around and started helping the hospitals and others sort of figuring out our planning for COVID here.
So when you say like epidemiology and public health is technically trying to use the data that we have compiled over the decades to predict what's going to happen in the future, so we can provide a better healthcare system for the patients, and we can, I like to say that you don't need to treat what you can prevent. Is that correct?
Yeah, that's right. And that's right. Still, like, the majority of, say, heart disease is still preventable, and as an example. So how can we help inform that, especially at the population level? That sort of, how can we, I think from a lot of the work we see, if smoking reduces a little bit, that's going to make a big impact. Not because it only affects heart disease, but lung cancer and diabetes, so many diseases. So how can we tell our patient is the community, how can we tell our patient what's the best options for improving your health? And typically, a lot of these are prevention. Although I look at medical treatment as well. For high risk, if you're a high risk patient, we have high risk parts of our community, then we're going to need to use hospital care and medications and others. But in general, a lot of times looking at what affects everyone, and what affects everyone is how we eat and whether we smoke and whether we're physically active. I think there's analogies to now infectious disease because we're all in this together. We're a community, and we can talk about that with what we're seeing with all these different models and things like that. But I think the analogy is still similar. We're one big patient. We're one big community, and what's going to happen to us in the future, and how best that would be the modeling, and how best we can deal with that.
When we think about the value of these predictive models and epidemiology and public health for making for really making informed decisions, we have seen on the news that countries they haven't paid attention to the scientists. They haven't actually listened to the scientists. But in Canada, I do feel that we have a good government and a good group of scientists really working together. And what do you think about that? You would think that in the sense of listening to the scientists and to the experts is the right way to go?
Well, I'm a scientist, so but no, I think in Canada, Canada's one of the countries. In Canada, the motto is peace, order, and good government. How boring is that? Not life, liberty, and pursuit of freedom. But that's peace, order, and good government. I think we kind of are following that, and that's making a difference. Working collectively, being thoughtful, thinking of others, looking at the science evidence. I think COVID is an example where the science is really been really important in every part of it. Like detecting COVID early stages, replicating the sequence within a few weeks, having that spread out worldwide, and then the models. I think the models have been indispensable. Like understanding the spread across the world, understanding our options, and I don't think that anyone has, like you look at in Ottawa. We're here in Ottawa. You and I are in Ottawa, and there was a poll from public health, and it was 94% of people support the idea of physical distancing.
Mhm.
How did we arrive at that? I think that to me says 94% of the people kind of believe the science that says that if we don't distance ourselves, we're in serious trouble. So I think that, like you said, there is extremely strong support and acceptance of the basic science that we're seeing.
So, in that sense, I think that we live in a beautiful country. We all know that really supportive. But the best examples we have seen so far from around the world is that those countries that are being proactive and really engaging not only scientists but also the community, and having a really good communication between the scientists to the community, and having the community really to rely on the government to make the right call. And I think this is a really good example. It's been really difficult for everyone, of course, and for the economy it's going to be really difficult. But I think that when we work together, it's going to be a much faster recovery. But the normalcy we used to have is not going to be the same for some time, and it's something important just to put it out in there, right? So, Manuel, we're gonna take a short break, and when we're back, we would like to hear about what you actually been doing in terms of research during this pandemic time and COVID-19. And I have many questions for you about the models and that kind of sort of stuff that is maybe too fundamental question, but I think that those are coming from a chemist. So we'll be back in 2 minutes, and stay tuned. welcome back to another episode of BEaTS Research Radio. So we're again streaming from my lab at the Hare Institute, and today we have us, Dr. Doug Manuel from the Ottawa Hospital at University of Ottawa, the Faculty of Medicine at the School of Epidemiology. So Dr. Manuel was telling us about how the predictive model and how public health has been so critical for the pandemic, for understanding the pandemic, how this is evolving, and how is eventually it's going to happen, the predictive model. So in the second part, I want to ask you more about you know how has been for you from working from chronic diseases from this long term predictive model to really taking all this information which is piling up probably on your computer and try to compress that and coming out with this predictive model.
How has it been? Well, part of it is not really research as well. But I don't want to be overly, I find the chronic disease models are very challenging. We got so many factors in, and the basic communicable disease models uh, are the basic parts that we currently use for these big messages about how to avoid being like Italy and others. You can do that with a fairly simple model.
Mm-hmm.
um, and um, and it's really been interesting for me. Like what I've been doing a lot of is not creating a new model, but really using existing models that out there. So instead of being a model developer, now I'm a model user, and applying our information that we have here in Ottawa to those existing models. It's been really incredible to see the difference between now and what we were in SARS. So now we have open science, which has taken a huge impact in how we do research and how we're doing research in COVID. So again, like having that sequence of COVID available internationally within 2 weeks, and now we can start developing vaccines not from having to culture the virus, but from the DNA sequence. And we're seeing this with models as well. There's a lot of groups that have made their models openly available, and then folks like me can take them, we can adapt them. I make issues, identify where there's problems with the models that need to be updated or changed because I'm using them. They're very open. I can examine them very closely. And so it's this whole community where we have these models, and everyone around the world is collaborating to develop them and make them better. I think that our philosophy in our team is that maybe a little bit different than some of the other modeling groups. That so the original request to me came from all the hospitals CEOs, like, Doug, how many beds do we need? We can see the numbers nationally, but what about locally? And I said, yeah, no, that's a good question. And I kind of take a view of modeling in general, but definitely modeling COVID. I make the analogy of modeling a hurricane. So and people say, oh, all these models are different, or they're not saying the same thing. Well, I sort of say, first thing, when you look at the long range for a hurricane, we can't tell where that hurricane is going to land on shore when the hurricane's out 1,000 kilometers, and we're clearing off the whole coast. We're giving warnings for the whole coast. Some of those people are going to have to move, and they didn't have to. But as that hurricane gets closer to the shore, we can start narrowing that in and refining those warnings. And within a few days out, we're pretty accurate. And I sort of say the same thing for COVID. One thing that we're doing that's maybe different is doing projections based on who we're seeing come into hospital. So not the test level. We know there's difficulties with testing availability and who's getting them, but we know who's arriving to hospital. And based on who's at hospital and the growth of that hospitalization, we can look out a few weeks accurately. And then 6 months out, it's going to be obviously a lot less accurate. And so that's the philosophy. But 6 months out, we can do the counterfactuals. What if we do physical distancing at 50%? Or what if we do increased contact tracing? And those counterfactuals are good. The actual level of numbers aren't, but the relative difference is good, is okay. So I'm talking on. Maybe I'll stop there and let
No,
you
it's okay. It's
catch
fantastic.
up.
So I think that the way I see it is that the globalization has played two roles in here, a bad one and a good one. The bad one is certainly like the spread of the disease so quickly, right? Because back in
Yeah.
SARS 2003, we didn't see it the spreading to the level we're seeing it today. They're two completely different viruses, of course, interrelated but different at the same time. But coincidentally, at the same time, the globalization has allowed scientists to communicate to a speed that is really unprecedented,
Yeah.
and I think that has been also critical for sharing information, for also sharing, like everything. Really, we have seen like it's an avalanche of all these, like reports every day on the internet, on the preprints of cases, clinical cases and so on. But it really resonated on me that from this COVID crisis, looking forward in 6 months or something like that, we are going to learn a lot of this pandemic of to be more prepared, right? To be prepared for something else that will come in the future. Is that correct?
Yeah, no, I agree. Um, we're responding very quickly to this one, but you know, will this help us in the future? I hope so, but I think everyone's focused on today right now and hoping that this is a hard won lesson for humanity,
Yeah. Yeah.
and that and that the better parts of us are going to make we're going to be better as a world for this. Yeah.
And when you were mentioning that you work with the Ottawa Hospital and maybe other hospitals within Canada, uh, like trying to come up with how many beds we're gonna need, right? So, and but we have done a fairly decent job, and I think that in terms of controlling the number of cases we are seeing at the hospitals. But now we're seeing a lot of cases coming up in the long-term residencies and home retirements and do you think of applying this model of expanding your research into those areas as well or not?
That's what we're doing this morning. Um, so, yeah, I think there's a few aspects of that question, but for sure, I think that we have a major problem here in long-term care, and other countries are having some similar problems as well. And I think what we're trying to do, say for our team with the modeling and working with local public health and long-term care institutes now as well, is that we had that first broad picture, and all the models were kind of agreeing for that. Moving forward, uh, we're going to have these local areas, and unfortunately, long-term care has been really affected. But I think looking forward, we can sort of say there's going to be these hotspots or these outbreaks in different centers. Like in here in Canada, we saw Alberta, like a
Mhm,
one
mhm.
packing plant where there's 500 people,
Yeah.
and COVID has the potential of spreading so fast that we're going to continue to get some surprises.
Mhm.
We're going to continue to feel that we were unprepared or we should have saw this coming, and I think we were unprepared and should have saw this coming in long-term care. And we're going to need to be able to respond very quickly with our surveillance systems, our monitoring, our control. So I think that's where we're looking right now. We're trying to now design our systems so that we can have that increased situational awareness um, in where these cases start increasing very quickly, identify them quickly, and be able to project and respond quickly. And we'll need that for the next year.
Yeah.
Um, and
Yeah.
we've set up our system too so that we can monitor, like critically, is hospitals, right? Do we have enough hospital beds and ventilators and ICU beds? And so what we view, again, like that statement of the hurricane, we'll continue that local forecast, that short range forecast, and say, are we tracking okay or not? If
Mhm.
we're tracking okay and we're below, then that gives public health and ourselves, everyone, some comfort and also some intelligence that we have some room to move our control measures and loosening physical restrictions or physical distancing or other things. So yeah, long-term care is a huge issue. It's a whole another challenge for even for modeling and projection because it's quite a bit different. Um, and but I think there's all sorts of situational awareness scenarios, projections that can look at options to control it very quickly if we, as quick as we can.
And I think that you mentioned something again really important, that this is gonna go for some time. And every time I discuss about this, I'm not an expert as you are. I know the epidemiologists of all the experts in virology, but it's important just to remind people about that. This is a long term thing. We're going to be together, And I think that having the predictive models to be able to retrofit to actually provide feedback to 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 probably make more informed decisions, like how we can lose the restriction and how we can actually implement the back and forth, because there is something that going on in the sense of the number of waves we're going to have, right? So we're just probably in the middle of the first wave in Canada, but we're going to have probably two or three more to go to come until the moment that we have a vaccine or something more mature to try to actually not control the virus, but to control the symptoms and reduce the mortality rate. Is that correct?
Yeah, I don't really look at it as waves. I think probably, I mean, here's it broadly. Like, there's three parts. The main part is what we know about the virus, and
Yeah.
we know how infectious it is and how quickly it spreads. And it's a tricky one. It spreads extremely quickly, and I think we're seeing more and more people. Watch this for your viewers. We're all working at home, but
Oh wow, I like that.
that's my secret. The
Mhm.
secret door for our
That's
house
a
here.
good.
That's my son in his bedroom. So we're all kind of working in different places.
Well, that's
Yeah, so I think we know how the virus is behaving largely. I think we're still learning some information, but we know, for instance, that it has the potential for explosive growth. These
Mhm.
2, 3, 4 day doubling times,
Wow.
and we're realizing that a lot of people get infected because you have those doubling times so quickly. It leads you to quickly say, okay, people must be getting infected very quickly in the early stages of or transmitting in the early stages of their infection. So we know the virus, and we can model that. And from that, we know that um, that if we relaxed our physical measuring now, or our control, it's just going to explode again. And because there's so much dry kindling, there's so many people that haven't had infection that can get infected. So the
Mhm.
models are very clear about that. There's no there's no um, confusion about that. Um, the um, the other part is very different. How it spreads is up to us. So I say, unlike the
Exactly.
hurricane, we can't change the weather system, but we can change the hurricane of COVID. And you see the models, like when people say, why are they different? Well, if we have about 70%, or actually, we're now currently around physical distancing effectiveness in Ottawa around 63%, that reduces the the peak of COVID by 99%.
Oh wow.
So that's the range. How effective are we going to be at adhering to what public health is telling us? Who knows? That's difficult to predict from a model perspective. But we know that that's going to affect the levels tremendously, as everyone knows now. We've seen this play out. So how humans respond to COVID is very difficult to model. So that part is incredible uncertainty. And so, yeah, we could have waves from that. The third part, I think we don't know yet about that third part, which is things like climate and weather. Like, are we going to see a reduction in COVID over the summer, like we do for other coronaviruses? And that can kind of contribute to the sort of second wave. But the main thing that's going to contribute to waves or increased growth is what we know about COVID, that it has the potential to have this this comeback once we get control, and how we design and adhere to control measures. So that's gonna be the two main factors for what happens in the next year.
Wow. This is quite you know good to hear in the sense that like a physical like distancing is critical, and we have been able to control it, like that number is 60% reduction, 60 something, that to 99% is amazing. I mean, I think that they're clearly not proportional, they're not linear. So it's uh it's really shocking to me to hear it, like, and again, I mean, we keep learning, and I think that this is an opportunity for scientists from different fields to try to also come together and try to learn a little bit about this pandemic, and try to see how we can all work together, and we can try to come up with simple solutions, because I think that like while we wait for the vaccine, or for learning more and more about the infectious process of this virus, it's important to actually be available for the community as well. So Douglas, and I want to actually thank you so much for taking the time. And you have been super busy, and thank you for all the work you have been doing actually for Canada. And keep doing these wonderful models. We keep following you. We're gonna have your Twitter account in here. It's gonna be there, and so people will actually be following you closely and waiting for your updates in the models and the prediction model you're putting together. And I would like to actually also thank to all the supporters from this radio show. This the University of Ottawa Hart Institute, the Department of Biochemistry, Microbiology, and Immunology at the University of Ottawa, the Faculty of Medicine at University of Ottawa Hart Institute. And again, thank you, Douglas. And I'm not sure if you have anything to say to our listeners before we go.
No, I think thank everyone for physically distancing themselves. I think that we're all in this together, and it's so hard. It's so hard to do, and if our work can help, show that benefit of that, I think that's one of the great outcomes.
All righty.
Okay.
Thank you, everyone, and have a wonderful day. And see you next time in another episode of BEaTS Research Radio. Take care.
Okay.